these were the two ends of her esophagus that we knew about, where this is where that suction tube is, and then we knew it was not connected. And on the contrast studies, we knew she had a little nubbin here. That little nubbin was the lowest I have ever seen it, and my senior partner, who's been in practice for 40 years, has ever seen it. So it was barely above the diaphragm, which is the breathing muscle here. So we had to kind of dissect it free of the diaphragm area. Then this time we freed it up from its attachment so that it could stretch longer. And actually it was nice and big and stretched out from 3 months of swallowing her own spit. So that was good. The reason why that was good was I draw it like this, but it was actually more stretched out like that. The reason why that was good was we mobilized or dissected this free, and we could pull it up maybe about that much more, okay? It's literally just this distal or bottom end is just a nubbin off of her stomach. It doesn't have very much there, okay? So we could stretch this up about maybe a centimeter. With this very stretched out top pouch from swallowing her spit for 3 months, I was able to hold it, stretch it, but also we do a flat, we call it, which is when I make a cut here, flat that down and then sew it into a tube to make her esophagus longer, to bridge the gap between here and here. So in the end, she is connected completely, okay? So that was our goal, because we talked about how the best esophagus you can have is if you use your natural esophagus tissue. Replacing esophagus with stomachs or colons or small intestines is doable, but it never has the best outcomes long term. So because she had such a nice stretchy big pouch here, I opted to do that flap technique to make the esophagus a tube to connect it, rather than plan B, which was to leave them and then put in those stitches I was talking, because that would mean repeat surgeries to go and tighten those stitches up. And repeat surgeries means repeat scar tissue. It means that this tissue gets weaker and weaker every time you pull it. So we felt that this was our best kind of solution, especially since she had a big floppy pouch here. So in the end, right now she's connected, okay? Her spit is theoretically going down, all right? But I draw it very purposely that it's a big fat pouch up here, and then it gets skinny, connected to this skinny bottom one, because this bottom part has never been used, so it's very skinny. So I had to in making the flap, when I flap this down and turn it into a tube, it becomes a skinny tube, but it also has to become skinny to match this skinny. So I draw this on purpose to tell you that there's a size mismatch between the top part of her esophagus that was collecting spit for so long into the rest of it. So we anticipate that there's going to be what we call strictures in this tightening, and that she will probably need those balloon stretches we talked about, because that is kind of part and parcel when you have such a big gap that needs to be reconnected. Okay, but that is better than having a colon for an esophagus or a small intestine for an esophagus. Okay? So it is connected, but there's lots of stitches making the new tube and lots of stitches holding this together. Okay, so she has that little chest tube that's coming out of her chest, so that if there's any leakage, it gets caught and it keeps infection away. Because if there's any leakage while this is healing, that all heals with time as long as there's infection is controlled. So that's why this chest tube is there, and because of all the fluid that gets accumulated, like I talked about. So that's what's sticking out of her chest, okay? It's right beside here to protect this, okay? I said I would have a nose tube in there, or a mouth tube. I actually decided against it, okay? So she does nothing except for the breathing tube right now, nothing in the nose or mouth. The reason why is because I didn't want to have a tube in here tickling all of this, and the chance of it making it not heal. So, and studies have shown that it actually heals better without it. So it's gone. Right now she just has her breathing tube. I talked to, this is a big cut site. It's through chest muscles. It hurts. She's going to be on pain medicine to make sure she doesn't hurt. The amount of pain medicine she's going to be on will make her very sleepy. So she's going to remain with the breathing tube through the weekend most likely. Reason why is this really, really hurts. It takes about 2 or 3 days for that pain to go down. So we don't want to see babies in pain because their heart rates go high, and then when their heart rates go high, they bear down, and when they bear down, they put stress on this. So she's going to have a breathing tube through the weekend so that she can get as much pain medicine as she needs without anyone worrying that she's going to stop breathing, okay? Because if the breathing tube is out and she stops breathing, and people beg her and push oxygen down, oxygen goes down your breathing pipe, as well as this pipe that I just repaired, and I do not want things blowing down it. So The breathing tube stays in for the weekend to allow her to have good pain medicine without anyone worrying she'll stop breathing to protect this repair. Okay. And she has a G tube. I've changed her G tube out for a new one because that one's getting old, and that granulation tissue, I kind of cauterized some of it away too. Okay. So 2 for 1, so she doesn't feel anything there. Okay.
Is it still a mini or is it?
No, it's a Mickey again, because that's all we had in the operating room. But if you like the minis better, it's easy to switch again. Yeah. Feeds wise, I would like her to not have feeds through the weekend because I don't want blood to reflux up into this connection and put acid on here. Acid burns. Okay, I should tell her to do that actually. I think IV nutrition. Yeah, exactly. TPN. Yeah. Okay.
That little tube right here, in time, will that get bigger? Or
Yeah, it does. But as it heals, when things heal, it scars. That's how things heal. By definition, it makes a scar. So when you scar something that's circular, the insides get tight. Right? It's circular. Anything that's circular, when it scars, it gets tighter. So we know that she's going to have that stricture thing, but we can stretch those out with balloons when things are healed. And then usually after many stretches, it just starts stretching. It stays in that spot. And then as the child starts to eat solids when the time is right, it stays open.
Will it be in proportion to the top portion once you're doing all that?
Generally not, because it usually doesn't get to exactly the same size as the top part, just because that wasn't how it was made, so it generally doesn't.
So as she grows, it grows
Yeah,
with her, right?
it will elongate with her. It will
But
get long with
will it
her.
always have, for lack of a better word, a deformation?
Yes.
Because
What we know is when kids who have had EA repairs, radio repairs, when they get older, and someone does a swallow study for some reason, they can usually tell where the joint is, because that joint is a permanent scar. So that joint is like a waist. It's a permanent scar that you can see there, if that makes sense. Yeah, so you can almost always tell it's still there. But it doesn't matter what the picture looks like as long as food goes down. So, yeah. So because how should I say this? I kind of think of it like I'm trying to think of a good analogy. Like a spandex, your favorite spandex. When it's brand new, it's nice and tight. When it's not new, it may look lumpy, but if it holds the things in, it doesn't matter what it looks like. It holds the things in. So that esophagus for her, if we were to X-ray or do dye tests, will not look like mine that's not been reconnected. But it doesn't matter what it looks like as long as things go through. But I would expect. So like we'll get to know each other for a long time, and she'll know me for a long time too. So if I ever do dye studies, I'm not necessarily looking all the time at what it looks like. It's more, well, can she eat? Can she swallow? If she can eat and swallow, doesn't matter what it looks like. We don't need to keep doing that. But I would anticipate that if she got one for some reason, I don't expect it to look like mine. But that's completely straight because I've never had a surgery. Okay, but those are long-term things. But for the weekend, that's the plan, Then kind of in a week or two, depending on how she heals, then we would get that first dye study where we shoot dye or allow her to swallow dye down to check that this is together and not leaking. And once we see that, that's when she'll be allowed to try more intake exactly. If there's any leakage or anything, it means it needs more time. She still is not allowed to bite. But it's why very early on she has a G-tube. So after this weekend, she'll be allowed to start having some G-tube feeds again. Okay.
that was the trickiest part, that little tiny nubbin.
I would say the whole thing was the trickiest part, was this tiniest nubbin that we had to pull up and then figure out how to reconnect it. Because plan C was we can't reconnect it, and we just have to put in stitches that are kind of like stretch bands, and keep it on stretch, and then go back to surgery a week later. Now that it's been on stretch and the tissue has grown, tighten it again like a winch. It'd be like an internal winch that she would need 2 or 3 surgeries to winch together. It works, but it's a surgery each time. The tissues get torn every time you winch it together. So if we can find a way not to do winching stitches or those tension stitches, we can, which is why we spent some time thinking about what our best option was, which was with a nice stretched out pouch of swallowing spit for 3 months. She gave me tissue to create that tube. The balloon.
You have to stretch it out.
Oh, no, through her mouth. Like if this scars down, the balloons go through her mouth, and then when it hits where it's tight, it blows up the balloon to stretch it.
That's an outpatient thing.
Yeah, out or in, depending on how she is. Yeah, but it can be outpatient.
Those are
Yes, in time those are dissolved, and nothing needs to come out or be removed. Yeah, in time those are dissolvable once it all heals together, but they don't dissolve until it's healed.
So, being that this is so short, do you think that, because I know we talked about it, you have to take a lot of time.
Yes. Good question. I anticipate she will have a lot of reflux because I didn't have to necessarily pull stomach up, but we pulled this up pretty hard that it changes the angle that she may end up having lots of reflux, okay? Reflux is usually treated with medications or sometimes changing the G tube to a GJ where the feeds go into the small intestine and not the stomach, and sometimes another surgery to wrap the stomach, but sometimes medicines is enough to control it, especially as kids get older and those muscles get stronger. I would say we had to pull it up, but we didn't have to make the stomach come up. That makes sense. Because the stomach was basically like that under here. She just had the smallest nubbin. So in stretching it, probably there's just a little bit of stomach. I'm such a bad artist, but yeah, it probably ended up looking like that, where this curve was being stretched out. Rather than being a banana, it's now more of a sausage. Okay. She'll be here. The G tube too early to tell because it depends on if it or when this heals. That's when she's allowed to start trying to eat or drink, and that she wasn't allowed to eat or drink for 3 months. So every baby develops those skills at different rates. If this scars down really fast, we need to balloon dilate it, but I won't balloon dilate it for at least 8 weeks after surgery because this needs to heal before we stretch it, right? Yeah, if it doesn't heal before we stretch it, it could just rip. So I don't know how long she'll have the G tube for. I was just about to say you will, you will. Reason why is my experience is that these kids will have the G tube for at least a year because sometimes it's good for backup. When they slowly learn, they are not stressed about getting all of their calories by mouth. They learn to eat food, but they also learn to enjoy it, and then they get the rest of their calories through their G tube. So it's not like it becomes stressful for parents to have to do that if it's an unpleasant experience. So those G tubes tend to stay for some time to allow that backup, so that learning to eat is a pleasant experience rather than a necessity that becomes unpleasant.
Just for visual, you did all that by hand?
Yes.
Oh.
In here is glasses and a lamp, microscope glasses that blow things up about 2.5 times, a headlamp, and I had a senior partner in there. She's been in practice for 40 years. There's nothing she hasn't seen, so it takes a lot of people and lots of equipment and things like that and time. So that's why I know that some people gave you some phone calls when able to just let you know things were proceeding, but it took the time to work too. Do you want to keep?
Yes.
Okay. I remembered you kept all my
the other ones.
Yeah, I remember you kept all my other pictures, so I did try to draw it kind of to scale. Okay. All right, you guys.
Not right now.
Okay. All right. This weekend, my partner, Dr. Jones, is on